Good morning, good afternoon, and good evening. Welcome to our audience and wonderful attendees for today. We have an exciting webinar. In fact, it's our third webinar in our 4 webinar series. And the Digital Surgical Pathway webinar series commences on. Today is the 13th of July, and we are in our third session titled The Benefits of a Digital Preoperative Assessment Pathway. Let me just recap with our wonderful audience and just set up some rules here. We are in our third series. Just as a reminder for what we've done so far, our first session was on the legal consideration concerning digitization in the surgical pathway, and with Al-Tamimi Co. It was around 14th of January, and then 14th of June. On the 29th of June, we went on to discuss the importance of informed consent with IDO Healthcare. And today we will have a series of a couple of panelists, wonderful scholars in their fields of expertise, who will be discussing a number of questions. We will still have one more session, so stay tuned. I know most of the people in the Middle East might be going on vacation for Eid, so I want to wish all the audience a happy Eid Mubarak, happy holidays for the next week or so. The fourth session will be taking place on the 2nd of August, and it will be on digital anesthetic data captured during surgery. And as you all know, the pandemic has pointed us to an important series of facts. Almost 30% of patients waiting for operations were having their scheduled surgery canceled or for non-clinical reasons. And this is a huge kind of disruption to the way that we provided care. Also, another piece of information that we got from Dubai Health Authority, the vacant nurse positions will increase by 460%, with vacant anesthetist positions growing to up to 190% in the next 10 years. And then another fact that has disrupted our way of providing care is it is estimated that 28 million scheduled operations across the globe were canceled during just 12 weeks of the pandemic at its peak. Again, these are all disruptive concepts and facts that have actually pointed us to start rethinking the way we look at healthcare, or might I say, the way we look at our sick care. Today's topics, we will be looking at 5 areas of coverage. The first area we'll be visiting is the differences between a paper-based assessment and a digital preoperative assessment pathway, in the hope to digitize healthcare and specific critical areas of healthcare, like the preoperative workflows. The importance of integrated data that is visible to all relevant staff to support collaborative working. And again, in this region, you will see a lot of push towards digital health integration, or what we call the health information exchange. So where integration is happening across the different health systems in this region. And then the third point of focus will be also on how digital can improve the patient experience while not leaving any patients behind. Again, very interesting concept to try and be more resilient in the time of the pandemics. Area 4 is to support and how we will be supporting the clinical decision-making process and identifying risks immediately in the hope to predict and preempt any disruptive events. And finally, we'll look at also the supporting telemedicine and virtual consultation processes to reduce face-to-face appointments in this new world of contactless post-pandemic era. So today I have the pleasure of bringing with me, let's start with introducing our panelists, Dr. Peter Houweling, practicing consultant, anaesthetist, and medical director of Synopsis. I also have Dr. Yasser Zaghloul, consultant of Anaesthesia at Sheikh Khalifa, Khalifa Medical City UAE and the director of Abu Dhabi Anaesthesia Club, and myself, your host, Mazin Gadir, external advisor to Dubai Health Authority and the director at IQVIA. So let me maybe start with questioning. Let me just bring in our panelists. I'm stopping the share now, and I would love to bring our panelists, Dr. Peter and Dr. Yasser. If maybe I start first with maybe a question. And the main question that I wanted to start with is, what are the incentives to move from paper-based assessment to a digital pre-operative assessment pathway? And if I, without any, I guess, chronological order or spelling, let's say letters order, let me start with Dr. Peter.
Thank you very much, Dr. Mazin, for the invitation to exchange the ideas about a digital preoperative assessment system and the whole surgical pathway. Yeah, it's very interesting. Let's tell my story. We started, let's say, around 2000 so let's say preoperative assessment has always been a very important stage in the whole surgical pathway. And when I came into practice, it was mostly paper-based. And the problem with paper-based is that we were always looking for documentation. We had to do with a lots of duplications, so nobody knew which diagnostics were done. We had lost medical records. We had illegible handwriting, so it was a lot of problems, and so it was no fun for the workers, for me as an anaesthetist, but it was also very dangerous for our patients. And I think in several times we had a bad outcome because of the data was not there. So there was an incentive to improve this, and I was very lucky that because I was a researcher at that time, still am, but did a lot of research, and we got a funding to improve the preoperative assessment, and so we got the funding to make a system which would benefit the patients, the workers, and also makes the whole thing safer. And you must recognize that we had in that time about 500 documents, so paper-based documents per week. So it was a lot of documentation. So the incentive for us was first of all, we want to support and improve the whole triage process. So we want to be able to have the right patient at the right time, so that we could focus on difficult patients and not the easy patients, let's say the ASA 1 and 2. We also wanted to facilitate faster pre-ops, because there were very long waiting times for patients, and because they have to run through the whole process. So we want to do it faster, and we were looking for potential to complete things over the internet. We also wanted to make it more transparent. So we had a lot of protocols in the hospitals, about probably thousands of protocols, but nobody knew what was in the protocols anymore. So we want to develop a sort of a system which had the protocols in the system, that you would be guided and supported by these protocols. Because we were working at several sites, we had several hospitals in the trust, we want to centralize the whole process, that so the data was stored in one place, but that you could make the assessment in the different places. And not in the last place, we tried to because the whole preoperative assessment is a very complicated process with many people involved, nurses, other doctors, consultants, cardiologists, often GPs, surgeons. So we want to have a system that could be accessible for all these people. And last but not least, we want to have decision support. So we try to build in a system with that people who uses the system were helped and supported by, let's say, rules, protocols, algorithms, what we call now artificial intelligence, but that's a big word. But let's keep it simple, and we want to have them guided by the protocols. So actually, that were the incentives we want to achieve.
Excellent.
So maybe that's a good start.
Absolutely, absolutely. Thank you for that. And maybe because I think I like the last point when you say guiding protocols, and maybe let me just get Dr. Yasser on the mic as well, in terms of as again in this region, where do you see the role of incentives to digitize more? And maybe you can think of your experience, Dr. Yasser. Go ahead.
Just maybe a short introduction that the trend is in pre-operative assessment, if you change it too much, maybe long time before the anesthesiologist is not seeing the patient in clinic, just during the admission in the hospital, or occasionally even directly before the surgery. So there is no proper pre-operative assessment and documentation as well. With the time and improving the anesthesiologist services, we have pre-operative clinic and pre-operative assessment in most of the hospital now. So no patient coming for elective surgery without proper evaluation and assessment in the clinic by the anesthesiologist most of the time. Occasionally, some hospital may use internal medicine physician, or sometimes they may use a nurse. It is different, but generally it is seen by the anesthesiologist. And at the same time, most of the documentation are on the paper written. So it may be missed and not proper documentation for some important information about the patient. Now, with digitalization of everything in our life, sure, we should digitalize our pre-operative assessment for proper documentation and for even for future assessment of the patient, and can be read by everybody. The pre-operative assessment usually by anesthesiologist, not the one doing the same anesthesia in the same time of surgery. So digital pre-operative assessment sure will help the anesthesiologist and may save proper for the patient as well. Maybe the questions I asked him for Dr. Peter before, how much this may change our clinical decision. This can change the anesthesiologist clinical decision, or can direct the patient to other specialty or medical subspecialty for pre-operative assessment.
Yes, yeah, the clinic, well, if you have a very experienced anaesthetist, the clinical decision is very clear. They are very good in making the right decision for the right patient. However, the difference between anesthetists, but also between residents, between nurses, between other people, is great, is huge. So what we tried is not, let's say, take over the whole medical decision in our system, but what we try is to support the clinical decision making. So what we tried is, for example, if a patient for pre-operative assessment, what counts is the risk assessment. It's not the questionnaires. A lot of people make the mistake probably that they think, well, if I fill a questionnaire, then I have a pre-operative assessment. But actually, it counts about the risk assessment. So what we thought was would be good, that we make, let's say, an estimation about the clinical condition of the patient. And so we make, for example, an estimation if the patient is healthy or sick or sicker with the ASA score. Everybody in the whole world knows the American Society of Anesthesiology, the classifications of the physical condition of the patient. So if you make an estimation of the illness of the patient, then it's a guidance for everybody who is doing the pre-assessment, because automatically you see, okay, this patient is probably healthy. I can see him directly in one stage, or this is a patient is more complicated and we need more consultations or more diagnostics or more whatever, more time for this patient or more preparation for this patient, or we have a ability to optimize the patient. So I think from a process view or perspective, it's very important that you have, let's say, information before you start the whole preoperative assessment. So the ASA score is one example. But for example, you also can have a cardiac risk or a pulmonary risk or other risk of patient. And if you are able to predict this risk, then it is a very good support for everyone who is involved with risk assessment.
One of the options may be mentioned by Mazin to minimize the face-to-face time between the anesthesiologist and the patient. Do you think is this a good option?
So again, can you repeat the question?
Yeah.
Can you repeat the question, Dr. Yasser?
On the telemedicine only without face-to-face interview with the patient. Do you think is this a good option?
Oh yes, absolutely. So what we were doing is that over the, let's say, the internet, so patients at home, they do the questionnaire, and so we said, okay, what's important to have on your scope? We're making a decision for if the patient needs to come to the hospital or not. So often it's the airway. So you need to have a little bit information about the airway. So we do a stop bank score. So by the form, and also we predict the ASA score, but also we predict, let's say, a general score. We include also the risk of the surgery, because if somebody comes for a cataract surgery, it's different than somebody who's coming for a abdominal procedure. So absolutely it's possible. Sometimes you need a face-to-face, but then you invite the patient to come to the hospital in a later stage or at the same time.
Can I interject, Dr. Yasser, and maybe because this question is very important, how can the telemedicine features be supported to facilitate the non-face-to-face interactions? What are your thoughts on this? And maybe I'll start with you, Dr. Yasser. Go ahead.
Yeah. Actually, many patients like to see their physician and to interact with them. So especially anesthesia for most of the patients a little bit vague. They don't know too much about anesthesia. They may understand internal medicine, they may understand the pediatrics, they may understand surgery, but the process of anesthesia is completely vague for most of the persons, not the patients, most of the population in general. And even for physicians, many physicians who is away from the surgical team, they don't know what is the exact surgery doing. That's why sometimes the face-to-face may be more calming the patient and more interaction with the patient.
Oh, I fully agree. I fully agree, Dr. Yasser. And I think we are just at the beginning of these telemedicine process. We now, if we think about telemedicine, it's most collecting information from a patient for a doctor or for a nurse, whoever. The next stage is also to inform the patients. So there is a lot of information we will send to the patient. And in the previous webinar, with I thought it was about informed consent. informed consent is a part, of course, of what we are doing in the pre-assessment. It's also to inform the patient about the risk, the complications, what he can expect. So so the whole pre-assessment process will be enriched by providing information to patients. The next stage, next step could be that we have virtual or video consultations, so that we can get face-to-face contact with the patient, and also by chat boxes, that if a patient has a question, you get a reply by a chat box. So I think we are now in the beginning of the telemedicine era, and this has been promoted and catalyzed by the pandemic. But I think we are in the first stage, and it will, the last important part will be the integration of vital signs to collect them from the patients by the smart watches, by the wearables, by other devices. So I think during the next 10 years, this will develop further. And the important thing is that you build a good platform, and then if you decide to go to a digital solution, keep in mind that important things are that it will be cloud-based, that it should be ready for the next steps in this development. So yes, it's a very important topic.
And I think, Dr. Yasser, thank you, Dr. Peter. Go ahead, please.
All right. Yeah,
go ahead, Dr.
No. This point is finished already. Yeah, I will go for the other point. For Dr. Peter, many of the hospitals using different software or different program to use for pre-operative assessment, or generally for the hospital in general. Do you think if we introduce Synopsis to different software or different program, is it easy, and can the anesthesiologist teach it easily to apply it in their practice?
Yeah, well, if you go back in history, what we started with, let's say, with solid small best-of-breed solutions. So we had a lot of these different software solutions, and what you saw is that the monopolized, the big mainframes, the big systems took that over. The problem with the big system is always that actually what they're doing is the handwriting paper, they digitalize it. So from let's say a mess on your desk with a lot of paper, you go to a mess in the computer with a lot of different forms. There is no integration in these in different forms. So, for example, a guy from the internal medicine, he writes down a blood pressure, and then the surgeon writes down a blood pressure, and the anaesthetist writes down a blood pressure. What's the right blood pressure? So in the mainframes, there is hardly any integration, and I always compare it with a golden pen. So it's a very expensive solution, but you didn't solve anything. So to my opinion, a best of breed option for pre-operative assessment, but also for other things like informed consent or PROMs or anesthesia information systems is the best solution. And you're right, you need to integrate it. And for me, one thing is always very important. That's a single data entry. What you want to avoid is that people or employees has to do the same handling 4 times in different systems. So integration is very important. And in the past, it was very difficult because we had actually no integration tools. We had HL7, but it was very rudimentary. It was not so good. In the meantime, we have HL7 version 3, we have FIRE, we have the clinical document architecture. So it's easier now that systems speak to each other and integrate. But one thing I want to mention in this webinar, what's very important, and most people forget it, is a terminology. If you don't have one terminology, or some people call it an ontology, then it's very difficult to communicate. For example, if you are an obstetrician and you say to an obstetrician, we do an induction, is a different concept if you say to an anaesthetist, we do an induction. The computer doesn't know. So it's very important that these systems have a terminology, and that's the way to communicate with each other. I've always stressed to at the moment, for example, SNOMED CT is one of the terminology worldwide accepted, which is important. So this is also, let's say, a important thing to consider if you buy a system, whatever, that it is cloud-based, but also has a terminology. And the best is a worldwide accepted terminology like SNOMED.
All right. Do you think we need a lot of technical support to introduce it in any hospital?
Yeah, you need an IT department who is supportive. So I think the most companies now are able to exchange the protocols because they have all protocols, they can exchange it. But you need to have an IT department who provides you with support, with servers, they need to give you access to also their systems. And for example, the PASS system, the electronic healthcare record of the hospital. I see the electronic healthcare record now more as a backbone with the essential, let's say, data in it, surrounded with a lot of best-of-breed solutions. That's my ideal view. And why I'm saying this, because let's say 10 years ago, the hospital was the place to go to. But now people are also treated at home or going at home faster. So you need also communication with the patient at home. So the whole concept of, let's say, one hospital system, I think it's an old-fashioned view. And I think it will not hold for a long time anymore.
Yeah. And the time for documentation. I am now in the pre-operative clinic and I saw the patient. Do you think I need a longer time to document the patient clinical data? Synopsis is friendly interface. I can use it.
You mean the interface of Synopsis to other systems, or what? Well, yeah, Synopsis has SNOMED, as a an HL7 interface with other systems. So we have integrated the system. We have integrated it with the lab systems, with the PASS system. We provide data to scheduling systems. We provide data to an anesthesia information management systems. Even we are able to connect to GPs. Yeah, that's absolutely mandatory, because if you have if the system functions as it is alone, you don't have the benefits of integration.
Dr. Yasser, if you allow me. Just quickly, I just want to make sure that the attendees are also, if there is any questions for the attendees, the interview is phenomenal, and the questioning and that is happening at the moment is very informative. I just want to make sure that our attendees are also putting their questions in the chat. If there is any question that you'd like to ask Dr. Yasser or Dr. Peter, sorry to interrupt you, Dr. Yasser. I just wanted to make sure that the audience are also following up with us. I'll give you back the mic. Go ahead, Dr. Yasser.
Yeah, okay. Yeah. For me, go for another point, you mean?
Sure, sure. I can throw another point, because I think what you are asking is also, I would love to see from the patient angle, from the patient side, in terms of improving the patient experience is one of the most difficult specialities to digitize, as you've put it. How can the patient experience be improved with the digitization of the pro-operative assessment process? And what benefits do you think the patient could have by the digitization of the pre-operative assessment process?
Many of the patients may have a chronic health problem which is not follow up well with the specific medical subspecialty. For example, patient with chronic obstructive lung disease, patient with chronic hypertension, patient with uncontrolled diabetes, patient with cardiac problem but not under follow-up for any reason, and he is coming for elective surgery. So he should be seen in the pre-operative clinic. And you're surprised that the blood pressure is not controlled, or the blood sugar is not controlled, or his bronchial asthma or his chest is not controlled, a lot of wheezes. So all these should be optimized before coming for elective surgery. So if I have some specific point, as Dr. Peter mentioned, like in Synopsis, which can point to the risk factor in this patient, which should be optimized or modified before coming to the surgery, of course, this will help us too much.
Yeah, maybe I can add something, Dr. Mazin. That's correct what Dr. Yasser is saying. From a patient perspective, we did research among 1,000 patients, and we asked them their feedback, how they experienced this way of doing the pre-assessment. Let's tell you the story how it went in the past. The patient came to the surgeon, was sent to the pre-op, or had to make an appointment and has to come back to the hospital in another day. So travel again. Then was waiting in the waiting room often for a long time, because there were a lot of patients or documents where we were looking for the right documents. Then had an appointment for, let's say, 10 minutes. And then they got the message, well, you're completely healthy. Thank you for coming. And you may go back to home again, and you will get an appointment for surgery. So let's say for the healthy patients, and let's say in a normal population, I think, well, 50% is ASA 1, 2. I think that's about the figures, maybe sometimes more or less. It's a time-consuming process. So the patients were very happy with a one-stop concept. So if they could things doing over the internet, if they got the message, oh, we think you're very healthy, and we do the physical examination on the day you come to the hospital for surgery. So that's a big gain for the patients. So they were very happy. Another point is that patients are now experienced or getting more experienced by the internet. They're getting a lot of information over the internet. So they are used to modern technology, and especially young patients like to use the technology. But also you as a clinician are better informed. So the disappointment for patients that surgery is cancelled, or what Dr. Yasser is mentioning, that they have a high blood pressure and go back to the GP for regulation of the blood pressure, can be avoided if you have the information on time. So you can ask to the patient, first go to the GP, regulate your blood pressure, and then come back again for surgery. So there is a lot of benefits for the patient. And what we experience is, so it was less time consuming for, let's say, the nurses, for us, for the anaesthetist, but it was also less time consuming for the patient, and they like that.
Yeah, maybe other point, Dr. Peter, as well. As you know, there is a lot of patients coming now, for example, in anticoagulants, and
Yeah.
there is no medication for anticoagulant. For myself, I can't follow all the new medication, when to stop, when to continue. Do you think you can help us in this issue?
Yeah, no, well, absolutely. So if you get the medication of the patient, um, um, I must say, since we are using this digital system, we have no troubles anymore with disappointment. Well, let's say never say never. Maybe it happens once because a patient doesn't understand something or make a mistake, but it's very rare now. So another point is that we actually don't avoid now any medical legal problems with patients.
Or
So cancellations, mistakes, fewer errors. It's all benefits the patient, and I think it benefits the outcome.
all right, yeah. And also, if the patient has anemia, you know, anemia is a major issue now. Also, patient coming for
Well,
major
that
elective surgery. Yeah. So we should have some specific pathway to treat anemia or optimize anemia before coming for
yeah,
surgery.
yeah, that's a good point. And as I mentioned before, I think we are now in the first stage of a
Or
huge technological revolution. I saw the first hemoglobin wearables come now to the market. The first glucose monitor is coming to the market. All wearables. So I
yeah,
think the whole the whole market for wearables and integration of these data will be utmost important. I can't wait that's coming to us, but I think that will come in the next 5 years, probably sooner.
okay. Any comment, Mazin?
Excellent. So I think no, absolutely. I'm very curious actually to put forward another question that came to mind, which is about, again, because you mentioned about the medical legal, and I want to bring in maybe your thoughts on what would be the most common clinical risks in the preoperative assessment pathway workflow that can be eliminated or reduced using digital innovation and pathways.
Actually, my imagination that the system should contain, for example, the endocrinology, nephrology, cardiology, hematology, and the most common 7 or 10 problems in these medical subspecialties. And to specify what is the clinical pathway for each one. For example, if a patient with hemophilia or sickle cell anemia, or patient with hypothyroidism, hyperthyroidism, patient with chronic renal failure, or patient at risk of post-operative renal failure, I think we should have some specific data or risk factors or pathway to be included in the preoperative assessment, even to predict the perioperative risk. And I think Dr. Peter has good experience in this. Correct, Dr. Peter?
Yeah, absolutely. I think that the biggest advantage is that let's say having centralized data, and if you have all the data which is completed in one central file, which is accessible for everybody who is taking care of the patient, could be nurses on the ward, could be the surgeon, could be the anaesthetist. But if you are aware of the let's say physics of the patients, I think you eliminate 99% of all problems. Because if you know if a patient is on anticoagulants, then you can take your measurements. If you know the patient has a ischemic heart failure, you can or postpone or take your measurements. And as clinicians, we are very much aware how to solve these problems. That's our job. The problem in the past was that we didn't were aware of what was wrong with the patient. We didn't have the information. So by having the information, I think that will solve a lot of these problems. And then in addition, you can improve it by acting faster, make it more comfortable for patients. But I think the avoiding errors is probably the biggest value of the digital systems.
Yeah.
Absolutely, absolutely, and I think this highlights. I mean, looking at the surgical pre-op workflow in the hospital environment, it's a huge driver for integration and putting the business case for interoperability within the hospital environment. And I thank you for your comments, Dr. Yasser and Dr. Peter, highlighting the importance of integrating different subspecialties and the concepts of terminology, and how important it is to actually try and unify the clinical terminology and the accessibility to the data across specifically for the pre-op assessment workflow, the clinical surgery workflow. So I think one of the questions that I caught in my notes is, I know you mentioned algorithms, and you mentioned also guiding protocols, the rules that will help in the area of preoperative assessment pathway. So I know everybody wants to bring in data to collect data for wisdom, and what is the minimum data set that needs to be present in front of the clinical workforce to make an action. So how are algorithms, and if I can dare say AI, provide the clinical decision support mechanism at this critical workflow in the hospital or in the healthcare ecosystem?
Peter, may start, okay.
Yeah, well, the topic of algorithm is also very, it's a difficult topic because people are also a little bit afraid of it, because it's not, it used to be transparent, but algorithms make something intransparent. You don't know what's happening at the back end. How is the decision taken? So when we started, there was nothing available. So I think in the beginning there were no guidelines. Well, there were guidelines, but there were no scorecards or algorithms or whatever. As you now search the literature, I think there are thousands of algorithms. So there are several ways to handle it. So in the beginning, we made our own algorithms. For example, we collected the data from and you ask another important question: how did you come to the data? What's the frame of the data you make your algorithms from? So many countries have a national data set, and the first thing we did in the Netherlands, but I'm also in the US and also in the UK, there exist national data sets with all the organs, cardiac, pulmonary, kidney, liver. All organs are represented in the data set. Demographics, coagulation, medication. So from this data set, we derived, we did research, and we tried to derive outcome. So we make a data set, and with logistic regression, we tried to predict which patients had good outcome and bad outcome. So that's, for example, we published a algorithm in the British Medical Journal, British Journal of Anaesthesia, excuse me, in 2011 with an ASA score system. So which are the components which could predict an ASA score? So this is one solution, that you make your own rules and your own algorithms, but it's very time consuming and you need to collect data, and with statistics you need to come to these rules. Another option is that you build in rules who are already known in the literature. So there are many rules. For example, we have a cardiac Lee index for cardiac risk. We have a PONV score from several guidelines. So we're doing two things actually. We're implementing rules who are known in the literature or from an institution. I think Dr. Yasser also has his own rules. So we can build them into a system, or we say, okay, you can, we have created some rules you can also use in your technology. So this is actually the way to do it. It's an option, but it's actually making a data set from pre, intra to post-operative care.
Excellent, excellent. Dr.
Okay.
Yasser, go ahead.
Yeah, actually, my imagination for the pre-operative assessment now, or digitalization of the pre-operative assessment, may help us in many other surgical issues. For example, Dr. Peter is aware about the enhanced recovery after surgery. Most of the surgical procedures have some specific protocol or specific guidelines for enhanced recovery after surgery. For example, after total hip replacement, total knee replacement, major colonic surgery, or spinal surgery, anyway. And there is a special component in each protocol or guidelines. The anesthesiologist play an important role to find this component is okay or no. So, for example, as we mentioned before, optimization of pre-operative anemia, or sometimes a patient coming with chronic pain and he using a lot of analgesic or painkillers before surgery, how I can control his pain intra and post-operative as well. So we should point for this issue. And if the patient has some clinical problem or even social problems not fit enough for the enhanced recovery pathway, how we can modify this point, how we can help our patient, all this aiming for short stay inside the hospital, 1 or 2 days maximum, even after major surgery. I think Dr. Peter understands me in this point. So if we have all these components in the pre-operative assessment, I think it should help the anesthesiologist and the patient as well. And at the same time, it saves the time of the stay or long of stay in the hospital and save money for the hospital as well.
Yeah, correct. We also use alert systems, for example. So if a patient has a difficult intubation, we highlight difficult intubation so that it is known to everybody. Or we highlight anemia if from a questionnaire we have to, it is suggested that the patient is anemic. We highlighted this. We give advice, for example, a guideline which diagnostics has to be done. Should there be an EKG or should there be certain lab values be measured? So there is a lot. So we advise PONV rescue medication. We predict if the patient will be very painful after an operation, so that there will be, let's say, more focus on pain management for the patient, or you can give a local regional technique in addition to the general anesthetic. So yeah, a lot of let's say alerts or warnings are also very helpful in these kind of systems.
And maybe, Dr. Peter, let me just pick that point, because it's very important, as you mentioned, to guide and safeguard the clinical staff involved in the preoperative assessment workflow. I mean, what are some of your thoughts on not to induce alert fatigueness, to the users of the preoperative?
Yeah. Well, that's a good point, Dr. Mazin, because a lot of people who start with this technology, they are afraid they fall asleep, and the system takes over, and they will get less alert and less focused on what should be happening. The experience, I have the experience also with the AIM systems, but also with the pre-op system, that people are very happy and actually are more, I must say, they follow, let's say, the structure of the program. So instead of forgetting things, they walk through the whole process, and actually what you see is they don't forget anything, and they are so alert that even if there are things which are not important, or they think, they skip it. So I think it's a different way of coping with this technology. So I think they're used to it, and as everybody now use computers and tablets and telephones. I think it's part of the way of living. So no, I can't say. And actually, the nurses are picking it up very easily, working with these systems. They like it. For them, it's very structured, and I think we notice that they are, let's say, in one day can be trained to use the system as they have never had anything else.
Excellent. Thank you, Dr. Peter. Dr. Yasser, I know you want to share something maybe from your experience as well.
No, maybe be another issue. Usually we have very busy pre-operative clinic, for example, 25 patients, 28 patients every day. So most of the patients, maybe as we classified them, ASE1, that they don't have medical problem and they can bypass the pre-operative assessment. But this, or in another word, can be seen or interviewed by the nurse, or even in home, as you mentioned about the telemedicine. So I can reduce this 24 patients to 12 or 15 patients, or maybe even less. If the nurse can interview the patient or do telemedicine with him, or if the patient has, for example, mobile application for the same program, Synopsis, so they can feed the specific data. And if we are query about some point, we can ask the patient, or me ask the patient to come to the hospital to see him. But I think most of the patients, at least 50% of the patient, they don't need clinic. Just by the telemedicine, or even the nurse interview on the phone, or by the mobile application, they can do the proper job in this situation.
Thank you, Dr. Yasser. And maybe just encouraging the audience in our last 6 minutes of the session, just if you have any questions, please do not hesitate to post your questions. Also, I would encourage our audience to also connect with Dr. Yasser and Dr. Peter as well, for taking the discussion into the, into the internet if needed, right? So if into personal messages. But maybe, as a final question, Dr. Yasser and Dr. Peter, maybe I want to bring in, again, the future, or let's say the future of the digitization of preoperative assessment pathway, and where would the what are the main efficiencies that you think should be focused on across hospitals to utilize a digital pathway? What are your thoughts on that?
Maybe to have a good answer.
Well,
okay.
I think hospital care will be probably changing in treating as many patients outside the hospital. So you want to keep, what we learned from the pandemic is that you want to keep patients out of hospital and not in the hospital. With the limitation of anaesthetists, of nurses, so the whole preventive medicine and also taking care of patients outside the hospital will probably be increasing. So the whole digitization is an important issue. So if we can monitor patients at home, if we can treat them at home, if we can have a good view of what's wrong with them at home, so a lot of things can be done by telemedicine. And the other point I want to stress is that if a patient needs to come to the hospital, then we need to have a lot of time to spend to the patient. So if the patient is really sick or needs a lot of attention or treatment in the hospital, so you want to have the right patients in the right place. And I think these digitalization will help us in the future to manage our patients better and to put our effort where we are needed. And if it is in the hospital, it's fine, but we also need tools and instruments to treat and take care of the patients outside the hospital. So I think that's my feeling that we will go this way more and more and more. And yeah, we're not there yet, but I think we started.
I think in general, regarding the digitalization, we should not focus in the pre-operative issue only, about the all pre-operative care of the patient to help us for the proper decision making. For example, some patient he may need post-operative high dependence unit or intensive care unit. Usually it is rough estimation pre-operatively. This patient may have heart failure before, or this patient had acute exacerbation of chronic obstructive lung disease. But if I have a specified score or point to specify if this patient has high dependence unit or ICU or not. For example, I will point for the severity of symptoms, about the treatment, about another organ involvement, patient has combined respiratory and the cardiovascular disease. If we have a specific score or point for this one to tell us and to can inform the surgeons and for the hospital administration as well, if this patient need post-operative care at which level. What do you think, Dr. Peter?
Yeah, I know. I'm completely agree what you're saying, and I think to handle this, probably you should go to a personalized medical file for each patient. So if the patient has his own medical file with all the data and all the information which is present, and share it with the hospital or with his physician where he goes to, that's probably an important goal for the future. I know some countries are working on this, and what we need to do is create information systems or applications which are supportive for these patients and which they can use in this file. So a pre-assessment application is important. A post-operative assessment application will be important. So example, if you send your patients at home the day of surgery, let's say what we are now doing is after total hip surgery, patient is going home the same day. So a couple of 10 years ago, he was 5 days in the hospital. Now he goes home the same day. So what you want to know then is if he gets, for example, atrial fibrillation. So you want to monitor his heart rate. You want to see if he is able to move, or that he has no fall incidents. You want to be able to control his pain. So the communication then with the patient at home, post-operatively, will be very important. At the other side, pre-operatively, you also want to be informed about the condition of the patient. So I think if the patient has his own file, is able to change his file, add information to the file, will be utmost important. And I think that's probably one of the steps we will go, and that's probably one
excellent
few in the future.
Fantastic. So I think with this wisdom points that came out of Dr. Peter and Dr. Yasser, the rise of personalized medicine, the integration of preoperative and postoperative workflow to create a holistic view that enables the resource utilization, the introduction of telemedicine to push the patient outside the hospital and transition care into preventative medicine. These are great points. I want to sincerely thank you, Dr. Yasser and Dr. Peter, for this great level of knowledge that you shared with our audience. I personally have got educated further. Thank you. And I would love the audience to always make sure that you stay connected with Dr. Yasser and Dr. Peter, and you've taken a lot of notes in this wonderful evening. With all happiness, I want to again put my hands together for Dr. Yasser and Dr. Peter, and let's make sure that we celebrate our wonderful audience by connecting with us in the next session, session 4, which is going to be on the 2nd of August. Stay tuned, get connected. Thank you, our wonderful panelists. Thank you, our audience. Stay safe, keep healthy.
Thank you, everybody. Thank you, Yara.
Welcome, and thank you very much.
Yes.
Enjoy your evening.
Okay, thank you, everybody.